Hello everybody, Xavier Lescure. I'm infectious disease specialist in Bichat Hospital in Paris in France, and I'm going to talk about physiopathology and treatment in COVID-19. Here are presented my disclosures, mainly general interest activities and academic research. For the cell invasion, it is important to know the receptor, which is ACE2, and the co-receptor, which is TMPRSS2. And after the viral replication and the maturation and virus release, it induces pyroptosis with the cytokine and chemokine and cells such as T cells, monocytes, and macrophage with a positive feedback loop. Mainly in adapted response, we can hope for infected cells rapidly cleared, virus inactivated by neutralizing antibodies with the minimal inflammation and lung damage. But sometimes we can have exacerbating response with the so-called cytokine storms, with excessive infiltration of monocytes, macrophages, and T cells. And finally, the severe or critical pneumonia and multi-organ damage with a phenomenon paradoxical, no neutralizing antibody increasing the viral replication. And because ACE2 and beyond the direct cytotoxic effect, the virus can induce a dysregulation of renin-angiotensin system with vasoconstriction, vascular permeability, and endothelial troubles with vascular disease inducing systemic diffusion. So we have lung disease, we have blood vessels troubles inducing heart, liver, kidney, gut, brain troubles in a systemic disease. You know that there is a initial viral phase with poor clinical symptoms and inflammatory response phase with associated with the severity of the disease, and there is an overlapping between the two phases during the week 2 of the disease. The latest advances of the understanding of the physiopathology is focused by the C5a factor complement, which is increased in the plasma and which is proportional of the severity of the COVID-19. And it could be an interesting avenue for try to prevent the excessive lung inflammation and the endothelialitis. And in September, we knew that there is a lot of patients, a large proportion of patients with critical or severe infection who presented neutralizing autoantibodies against interferon, which is another avenue for improving the evolution of the disease. For the treatment, you can play at different sites of the viral replication, or you can try to have an action and a modulation in the inflammation. You can, for example, try to inhibit the penetration of the virus with camostat or ACE inhibitor. You could try to inhibit the endocytosis with chloroquine or hydroxychloroquine, but it doesn't work. You could try to inhibit the protease, but it didn't work with the lopinavir. You can always try to inhibit the polymerase with remdesivir. We are going to see that in details, and you can play with immunomodulation with corticosteroids, for example, or tocilizumab. You can also improve the procedures of oxygenation or to optimize the thromboprophylaxis, for example. For remdesivir, the main results recently presented, published in New England Journal of Medicine or in medRxiv are the ACTT1 for the final report and the preprint results for the Solidarity study. The first one showed significant positive impact on the time of recovery in COVID-19 in a double-blind placebo-controlled RCT realized in the US with virological proved inclusion criteria in more than 500 patients in each group. But this RCT didn't show significant difference in terms of mortality, and it's the same in Solidarity. No impact, no effect of remdesivir on the mortality of patients. It's not controversial results because the criteria are different, and probably we have not enough sensitivity in the criteria because it's an antiviral drug, so it's difficult to assess very precisely the action of the virus with the mortality of patients, and probably the very narrow window of viral disease is difficult to assess in terms of intervention with the so large inclusion criteria. And this is the message of these slides. We can see the difference of effect of remdesivir according to the supplemental oxygen needings. And for example, we can see on ACTT that the impact is more important when the oxygen is in low flow, probably more earlier phase of the disease. For corticosteroid, the effect is clearer documented with the recovery RCT realized in UK. It's open label one, a large number of patients in each group, pragmatic inclusion criteria without always virological documentation, and you can see that there is a significant effect of dexamethasone in patients with oxygen and even in patients in ICU with invasive mechanical ventilation. You can see as well that the effect is not clear for patients without any needing in oxygen. So you have to put dexamethasone only in patients with supplemental oxygen therapy. And on this meta-analysis, you can see that if you don't have any dexamethasone, you can probably use hydrocortisone with a very close effect, even if we don't have enough patients to be. And now for tocilizumab. For tocilizumab, the results are very difficult to interpret, and it's difficult to conclude today on tocilizumab. We have recently published works, two open label RCT, one realized in Italy and the other in France, with a similar design, with the similar very close inclusion criteria, but not the same endpoint. We can explain a part of the difference because the Italian RCT doesn't found any difference according to cumulative clinical worsening. And the French study show a possible impact in probability of death or mechanical ventilation. The study realized in US is different because it's an observational retrospective study, a large number of patients, and a significant effect on mortality at day 28 and even 40. And very recently, 2 days ago, another RCT was published in New England Journal of Medicine and show no effect of tocilizumab for the mechanical ventilation or death, a composite criteria. And the problem is that this is a more strongly designed RCT because it's double-blind, placebo-controlled with a large number of patients. So it's very difficult to conclude for tocilizumab, and it could be explained by the fact that finally in COVID-19, even in critical patients, the level of increasing plasma interleukin-6 is not so strong, so important compared to other model of CRS, such as sepsis or CAR T cells. So research has to go ahead with other hypotheses. We have to definitely conclude for remdesivir. We have probably to add to complete the immunomodulation, probably in case of non-response to corticosteroid. We can try to research impact on monoclonal antibodies. There is still a large research to find a solution for the COVID-19. But today, in conclusion, it's important to well know the standard of care with supplemental oxygen, optimization of the supplemental oxygen, and thromboprophylaxis. It's clearly documented that dexamethasone has an impact in the inflammatory phase of the disease. It's less clear to what to do in case of non-response to dexamethasone. Is it possible? It is possible probably to have tocilizumab, but it's not documented. And the remdesivir has probably a place in the strategy, but at the early phase of the viral disease. Thanks for your attention. And if you want to see more details, you can upload the important slide set on the link from core band reacting performed in France, and with an update each month. Thanks for your attention.